Sarah, thank you very much for sharing your experience with us. It's not easy, recounting all of that for you, many painful memories, and a really scary time for you, and a scary experience. And you really are, brave and certainly a true warrior, and you absolutely deserve that title. And it's a pleasure listening to you. Thank you very much for that, for sharing that. We have just before lunch now. Lunch is at 1:30, so we have the bones of 10 minutes, and I'm going to ask the presenters of the sessions just gone to come up and join me here, along with Professor Levy, and I will open it to the floor for any questions that anybody might want to ask, and the panel can jointly answer them for you. I think it would be useful. And can I just encourage you then, when we get to 1:30 at lunchtime, take the opportunity to look at the posters. There's lots of great posters showcasing the work nationwide. So do have a look over those during your lunch break as well. Sarah, would you like to join us? Sure.
So I think it's really important, if people are unclear about anything or have any concerns about the direction, that this is an opportunity to discuss the issues, because one of the things that we really value with the national programme is engaging with end users in the direction that the sepsis programme goes in. It's very much a joint venture. So we'll be very happy to answer any questions or give any clarifications that anyone might have.
I might start it off, Vida, from over here. So just in my experience over the last couple of years, prior to having a sepsis programme in the country, and then, through yourself in setting it up, and the model you've set up, which is yourself as the clinical lead and Christina as programme manager with you, and then the model of having an assistant director of nursing as the sepsis lead in each of the hospital groups. As an observer, that seems to have worked really well, and as a model in terms of progressing things nationwide. How do you find that? Has that worked well for you?
Well, it has, but of course it was a compromise model. What we'd really love to have is to have a dedicated sepsis clinician in every hospital with dedicated time. And some of the hospitals did take the decision themselves to appoint sepsis nurses to help guide their implementation programme, because although we have sepsis committees in every hospital, those are clinicians with their pre-existing responsibilities, and to have somebody with a dedicated time, there's no doubt it has a huge impact in the ability of the hospital to respond to the sepsis programme. And we've had really fantastic change in hospitals, all of the hospitals, but in particular the hospitals with a dedicated resource. So in the absence of being able to get the funding for a sepsis nurse in every acute hospital, we went with the group model. At the time, the models were just being developed, so it was very much within the zeitgeist, and we were able to get that resource, and it's been fantastic. Our sepsis aid-ons travel amongst, up to 11 hospitals over very wide areas, visiting all of the hospitals, providing sepsis education, participating in the sepsis committee meetings, and very much in particular doing sepsis audit and feedback of that audit. They provide quarterly reports to the group leadership of the sepsis implementation in all the hospitals and at a group level. And then, of course, provide reports for the national report as well. So, yeah, it's been a really important method of measuring what's going on in the hospital, and then measuring the change that's going in the hospital, so that we can inform clinicians of the effect of the work that they've been doing.
Thank you for that. Any questions now? If you would just raise your hand. Okay. Two down here, yeah.
Hi, it's more of a comment than a question, and it's just something I picked up from the two girls, the survivors of the sepsis, that is quite interesting, because I also suffered from a sepsis experience a number of years ago, but not to the extent that they did. But the issue of the visual disorder, if you want, is very, very kind of still forward in my memory, to the point where the staff that were looking after me, I got a very early diagnosis and was treated very well, but I still, on day 4 of the experience, everybody appeared, like they look in those funny mirrors in a fair. Everybody appeared that distorted sort of and tunnely vision, and that went on quite a few days because I wasn't on the right antibiotic. So I think the issue of the visual disorder, even very early on in the sepsis, is actually really important, because it was the thing that triggered in me that I knew I wasn't quite right and made me bring myself into hospital. And I just noticed the 2 girls who spoke actually picked up on the distortion of lights and of tunnelling and colours. And I remember all those things, even though I was early treated and really never got to the point where those girls did. I just think it's really just interesting that they brought it up.
Yeah, so sepsis, as I think everybody knows by this stage, causes organ dysfunction. So as part of our patient information leaflets, we've got a sepsis checklist. And while we don't specifically talk about visual disturbance, what we do ask is for patients who have an infection and where they're getting worse, if they develop any signs of where they're functioning differently, that they need to consider, could that be sepsis, and they need to inform their clinicians. So we go through all the different organ systems. We talk about the brain, is there confusion, agitation. We talk about functional status. One of the very common symptoms in young adults is severe leg pain or the inability to get out of bed and weight bear. So if you're not doing what you normally are able to do and you're getting worse because of an infection, you're feeling sicker because of infection, you really need to attend your clinician and ask, could this be sepsis?
And I think for me as well, it was the fact that they hadn't taken any history about what had happened on the 2 days before, where the view of me in the bed was completely different to how I presented to A&E, because by that point I had been out of bed and I believe my adrenaline had kicked in, and so I was fighting, and I wanted somebody to recognise that I was sick, but that transpired that I wasn't confused and that I was able to walk and talk. But then if you know me, you would know that I wasn't talking in the same way as I would normally talk, and so to ask the history and to ask the person that has come with you as well, because if they'd asked Ian, he knew I'd grunted at him for 2 days where I couldn't actually physically speak. So that's one of my, what I would just have liked someone to have listened a bit more at that time.
This is a really important point. The reality is that young healthy people compensate really well up until the point of complete collapse. And we hear over and over again stories of people being, they were fine, and then suddenly they have a cardiac arrest.
Yeah.
Young people don't have sudden cardiac arrests from sepsis. They had a prodrome, it may just be hours, but more likely it was days, where they were unwell and they compensated, and their heart rate goes up to maintain their blood pressure. By the time a young person becomes hypotensive, they're in a very late stage in sepsis.
And to have such a high, when I left the hospital with the CRP level of 404, which I only know in history, looking back on my notes, how long was I going to survive at home with my CRP level and infection levels rising? I'm estimating it's 48 hours, but my blood pressure had already dropped below 100 at that second trip to A&E. So, I could have crashed at any time during that time, and I wouldn't have survived, or I would be in ICU. So, I know that I'm the story where I do get treated early, but I still waited 14 hours to be treated, and, there must be something better we can do.
Yeah, go ahead.
Just a question for Sarah. Do you know, was there an early warning score in the hospital or a sepsis policy or protocol?
Yes, I have all of those. I've now learnt about new scores, and I can debate new score 5 with you till the cows come home. So when I was at the hospital, my new score, or when I went to the out-of-hours doctor, my new score would have been around 3. And when I first presented to A&E, it was only at 2. And that's because my respiratory rate stays pretty stable the whole time, and so I don't really get a high new score, and that's something else that you also need to look at the patient and ask them. So I do hit a new score of 4 at one point, but in Northern Ireland, we've got new score 5 equals SIRS, and so I wouldn't ever have hit the new score of 5, but I still had sepsis. I had sepsis on that day at 2 a.m. in the morning when I woke up dripping with sweat and spent 2 days in bed. So if I hadn't have gone to hospital, I would be dead anyway. And it is about, I laugh now because new score is a tick box, and I've never fitted in any boxes. I'm always outside the box, so I didn't fit in your boxes of ticks. But if someone had have gone through, I had things to, and I had all the SIRS criteria, so they just didn't all think of the big picture. They just saw pneumonia, and that was the diagnosis, and not that it had gone any further than that.
Okay, thank you. One more down there, yeah.
Hello, I work in a 169 bed care, the older person facility, and I was very interested to hear you talking about there's work being done for the residential care sector.
That's right. It's at a very early stage at the moment. So we've been working with some clinician colleagues, and we've put together a sepsis form that we're going to be piloting simultaneously in the GP study, but the GP office, but also with some residential units. We're starting off with St. Mary's in the Park, and in fact I'm meeting them on Friday, but they have a much higher level of care, and there are a number of units that are similar to that, so it's likely that we'll have to spend a little bit of time targeting or matching the forms with the type of care that a residential centre provides, because once again you don't want to create a scenario which leads to over-diagnosis and over-treatment, and we want to get that balance right so we can give the correct treatment to the right patient.
Yeah, because we do have considerable difficulty with recognising infection and then when it's going into sepsis. So I did mention we are 169 beds if you want to trial another form.
I'm always looking for places to pilot.
Yes. We've taken a picture of you. There's no getting away now. Look, just in relation to ticking boxes, I feel as chair of this morning's session, Geraldine Shaw must tick a box and bring you in at the time, 1:30 for your lunch. Otherwise, you won't be too pleased with me. So I'd like to thank this morning's speakers, Professor Levy, Sarah, Vida, Grania and Deirdre for sharing such inspirational presentations and bringing us up to date in terms of what's happening. And again, I encourage you to have a look at the posters during lunch and enjoy your lunch and enjoy networking. Thank you very much.